So the next talk again, we need Dr. Borek Foldyna to be here virtually, and we will start his talk, a pre-recorded talk.
Hello everyone, my name is Borek Foldyna, and in the next 25 minutes I will be talking about pre-intervention planning for non-valvular and electrophysiology procedures. These are my disclosures, none of which is related to the current talk. I decided to primarily talk about atrial fibrillation and the left atrium since this is the clinically most relevant topic. And in the second part of my presentation, I will be focusing on the ventricular tachycardia and the role of imaging in identifying left ventricular substrate. Also closely related to atrial fibrillation and prevention of stroke is the left atrial appendage closure after the introduction of the left atrial appendage closures in 2007, and these devices such as, for example, the Watchman device here, there have been multiple multicenter randomized trials that show that this relatively new method is at least non-inferior to systemic anticoagulation. And like in other minimally invasive procedure, the preoperative planning is crucial for the success of the procedure. And here you can see an example how we measure the left atrial appendage before the Watchman implantation. And what we do is, similar to the pulmonary veins, we angle in multiplan reconstruction the ostium of the left atrial appendage, which is going to be the landing zone for the device. And here we provide the minimum and maximum diameters as well as the circumference of the ostium. And then we provide the length of the longest axis here. And as you can see here on the right, this is after the implantation. And here we can see the Watchman device with this covered part here in the beginning, and then the uncovered bear springs here, fully thrombosed as it should be. The postoperative imaging focuses on the detection of para-device leakages, as you can see in this example here. Here you see that the device is not thrombosed, and we have this relatively large 9 millimeter times almost 7 millimeters para-device leakage, which connects the left atrium with the left atrial appendage. And we usually say that leakages that are larger than 5 millimeters are the crucial ones with residual cardiovascular risk and risk of stroke. That's why everybody with a leakage over 5 millimeters should be anticoagulated. Okay, so that was about left atrium. Let's look at the ventricular tachycardia. So ventricular tachycardia is closely related to sudden cardiac death, and you know that cardiovascular disease, especially in the US, is very common. Sudden cardiac death accounts for 50% of all cardiovascular deaths, which was in 2020 more than COVID-19 deaths. Majority of ventricular arrhythmias occur in patients with structural heart disease, and 50% of the sudden cardiac deaths appear in patients after post-myocardial infarction due to ventricular tachycardia. And you see that the distribution is very heterogeneous across the US, focusing mainly on the southeast of the US. So what is the concept behind VT? And this is a concept known since 1978, so it's almost 50 years. And what it actually shows us is that we have these areas of scarring after, for example, myocardial infarction. Here, gray. We have the healthy myocardium, which is white, and we have these areas, these so-called channels or corridors that are actually these so-called border zones. And these border zones propagate the electrical impulse slower than the healthy myocardium. And the scars itself is actually isolating, so it's not propagating the electrical signal at all. And what can happen is that at the end, when the impulse reaches the exit, it can actually go backwards and lead to a re-entry. And on the right side, we have actually CT-based imaging, which simulates the re-entries. Let's play it on, and you can see here nicely how the VTs can be visualized using this computational method. Here, gray is the scar, and we see our circular kind of re-entrance into this channel here in the middle. So what is the role of the ablation in these patients with VTs. And we see that besides giving these patients an ICD, catheter ablation is pretty much an option in everyone, for example, in patients with not sustained VTs, but also with sustained monomorph or sustained polymorph VTs. And we see that patients who undergo ablation have significantly better outcomes even after 4 years of follow-up. So how does the procedure look like? So first of all, the EP lab usually performs a electroanatomic mapping, and they make all these voltage maps where you can see everything. What's this magenta color? It's a healthy myocardium, and everything what is red is a scar, and everything this greenish yellowish color is the border zone. And we know that they are trying to find these border zones and put ablation in there to stop the VTs or to prevent the VTs. However, this mapping and ablation procedure is relatively long, especially in the ventricle, and it can easily take between 5 and 6 hours. And we know that with longer procedures, the risk of hospital mortality goes up. But we also know that, for example, if we guide our ablation with imaging, that the time needed for the procedures goes significantly down, and it's also related to better long-term outcomes. So imaging can guide the ablation procedures. And it also increases improves the outcomes of the patients in general. So on the left side, we have a distribution of patients who underwent VT ablation, and we see that 2/3 of the patients had partial success, but there are also a large number of patients with failure, about 11%. And if we perform a prior MRI to guide the ablation, we see that the number of complete success increases, and especially we have a significant decrease of failures. And this is reflected also in the results of the multivariable analysis. We see that pre-ablation LGE MRI imaging is associated with almost 8 times higher odds of procedural success. And this success is seen in this Kaplan-Meier curve here on the right, that it persists even after 2 years of follow-up. So what is the main aim of the ablation? It's the so-called MRI-based channeling here. So in this trial, the EP lab fused the MRI images together with the electroanatomical voltage map. And you can see that MRI can actually nicely identify the so-called channels or corridors here. And these can be then targeted with the ablation, which at the end leads to a reduction of VT recurrence to 90% from initially 44%. So let's look at the myocardial fibrosis and the scar a little bit more closer. So these are the different types, and this is nice histology work already from 2018. And on the left, for example, you see the ischemic heart disease with this dense reddish scar, and yellow or orange is the vital myocardium, and you have this borderline or border zone around it. And we have all the other patterns here on the right. And we know that MRI can really nicely image the scar, especially our LGE imaging corresponds well with histology. This is a porcine model. And but from the daily practice, you know, the MRI is really good in imaging, especially scarring after myocardial infarction. So you would expect probably that there is a good correlation between the scar on MRI and the impaired voltage on the electroanatomical voltage maps. Unfortunately, there is a considerable mismatch. Approximately 1/3 of the cases show a mismatch between the LGE on the MRI and the electroanatomical maps. So why is that? And there was a nice study published in 2011 already that shows that as far as we have a transmural scar, then the correlation between LGE and the electroanatomical map is pretty good. You can see it here on the left example. But as far in patients with non-transmural scars, for example, this patient with a large subendocardial scarring in the inferior wall, there is only a poor correlation between the electroanatomical map and the LGE. Unfortunately, the scars that are not transmural and are more heterogeneous are those dangerous ones, where we have large areas of the so-called border zone, and the larger the border zone is, these are the yellow area here, the worse is the outcome. So we are actually looking for scars that have a large areas of this border zone. But MRI can help us with this. So what we can do with an MRI is actually look at certain layers of the left ventricular myocardium and identify so-called corridors. So in electrophysiology, we call these channels, but in imaging, we call these corridors. And these corridors usually connect healthy tissue. So we have an entry and an exit, and they go through an area of this borderline abnormal myocardium, which is this yellowish greenish area here between usually two isolating dense scars. And this represents these so-called conductive channels on the EPU, and there is another study showing actually that these so-called corridors really nicely correspond to the 3D electroanatomical voltage maps. So what are the criteria for a corridor? So as you can see it, the post-processing software enables mapping of the myocardial substrate as follows. It identifies the myocardium in the layers from endo to epicardial and maps the signal intensity. Here, systematically white represents healthy tissue, thick scattered is the dense scar, and the thin scattered areas are the border zone. The criteria used to define corridors are: one, the presence of entry and exit, and two, border zones surrounded by dense scar. So for example, here in these examples where we have a vital myocardium in an area of this corridor, this is not called a corridor. Or if we are missing, for example, an exit or entry, this is also not considered a corridor. So the software automatically recognizes these areas that are potentially corresponding to so-called channels on the EPU. So let's look at the software itself. So here, red, we have our dense scar, we have our healthy myocardial tissue, which is coded as blue, and we have this corridor here in the middle. Here is an example from the clinic where I used to work. So this is a 65-year-old male. Ejection fraction is mildly reduced. He has a chronic anterior wall myocardial infarction. We did a 3D LGE MRI, which was a adapted version of actually the DCAP protocol. And this patient had an inducible ventricular tachycardia. He did not have an ICD before the VT ablation, which was good for the imaging. And the ablation was aided by MRI based on 3D PSI maps imported into the CARTO system. So what we can do is we can use the software we have to create a 3D maps that can be directly imported into the navigation software. So let's look at how it works. So these are our 3D images. And you can see the layers, what I talked about, going from endocardial to epicardial. And let's stop and let's just scroll through. And I'm going to show you, for example, here is this large corridor connecting the healthy part of the ventricle here and healthy part of the ventricle here. It goes through the area of border zone, and it's isolated through this large transmural isolating scars. And this corresponds really nicely to our channels on the EPU map. You can see that we uploaded and we targeted this channel and could prevent the VT recurrence. There is another patient with a little bit different concept. So this is a patient with a large inferior wall infarction. And here we did not use our own software, but we sent it over to the Trianova lab at Johns Hopkins University. And what they do is they kind of create this 3D mapping of the substrate of the scar itself. But the more innovative and a new part is actually a virtual pacing. So what they do is they go and pace certain areas of the myocardium, and if we have our little piece of the scar right here, which is this dark area, and they pace in this area, we would expect that electrical impulse goes away from this pacing area, and you will see that actually after maybe like a third or fourth beat, we will have a little re-entry where actually the impulse goes the other direction. So let's look at it once. So we see it's coming this way, which is correct, but it's going to go slower and slower, and now we see that it went actually the other direction. So this virtual pacing actually could induce a VT in this particular patient in this particular area, and we could target then this particular area in the EP lab and could prevent the VT reoccurrence. There are also multiple multimodality approaches. For example, the music study is one of the most famous one. Multiple hospitals are working or were working on this concept, including the hospitals where I used to work in Germany. And what you can see here, they are trying to connect the CT imaging, the MR imaging, but also the EKG to map the substrate. And this is just a feasibility study already from 2014, and this concept is still being worked on. So there is still a lot coming our way. To sum up, the role of cardiac imaging for EP procedure planning is still expanding. Pulmonary vein CTs and MRs became routine, especially for imaging of the anatomy and for exclusion of the left atrial appendage thrombus. The imaging of arrhythmogenic LV substrate is feasible, as we could see on MRI and CT. The implementation of imaging improves efficacy, leads to shorter, simpler, and more successful procedures, especially for the ablation of the LV substrate. And we also saw that 3D LG imaging is challenging in ventricular patients. For example, the duration or regular heart rate plays a role, and large multi-center randomized trial are unfortunately still missing. Thank you very much. Hello everyone, my name is Foldyna, and in the next 25
Thanks so much,
minutes,
Borek. That was excellent, and it was really very relevant for a lot of us here who are radiologists and don't.
I think we skipped some part of Borek's lecture, so we'll be playing that part, the initial 1 minute part. That's what he has asked for.
Here we have.
Well, maybe I'll just give a quick update. I mean, I showed on a few slides at the beginning, which were skipped, the measurements for the pulmonary veins for PVI procedures. I'm not sure if it's something. Here we go.
Ventricular substrate. Let's start with atrial fibrillator times almost 7 millimeters para device leakage, which connects the left. I only talk about atrial fibrillation. And let's start with atrial fibrillation. We see that atrial fibrillation is a global issue. The prevalence of atrial fibrillation increases with age and is higher in men compared to women. We also see that atrial fibrillation is most common in North America, followed by South America, Europe, Eurasia, some of the Asian countries, and then Africa. This distribution is most likely related to the median age of the populations. In the left lower corner, we also see that we expect the prevalence of atrial fibrillation to increase in the next few decades. Regarding the imager, the current guidelines recommend variety of imaging modalities for the analysis of the left atrial anatomy, structure, function, and to rule out left atrial appendage thrombus. Many of you probably remember the DCAF study. It was a base for the Utah classification and shown an association between the left atrial late gadolinium enhancement, which they described as a substrate or maybe a scarring, and recurrence of atrial fibrillation after pulmonary vein isolation. However, the more recent DCAF-2 study did not show a difference between MRI-guided pulmonary vein isolation compared to standard ablation procedures. So really the real purpose of the imaging in patients with atrial fibrillation remains the pre-procedural planning, including description of the left atrial anatomy, including number, location, and the size of the pulmonary veins, and also ruling out the atrial thrombus. Post-procedural imaging focuses on the detection of complications such as pulmonary vein stenosis, atrioesophageal fistula, and phrenic nerve palsy. Here you can see the procedure. So the procedure, the EP lab goes through the inferior vena cava, transseptal approach, and then towards the individual ostia with the ablation. And here you can see the corresponding EPA image. Let's look at the MGH example. So here on the left, we have a 95-year-old male with atrial fibrillation. We usually describe the size of the atrium. We describe the position of the esophagus relative to the pulmonary veins. We see that here we have the esophagus relatively near to the right lower pulmonary vein. We talked about usually the left atrial appendage and rule out thrombus in this area. Then we do the pulmonary vein measurements. Here is an example of the right upper pulmonary vein. This is this guy here. We angle in our multiplan reconstruction the vein perpendicularly and provide the maximum and minimum diameters. We also provide 3D reconstructions that can be imported into the Cartwheel or arrhythmia software or in the workstation itself and used for the navigation during the procedure. Also closely related to atrial fibrillation and prevention of stroke is the left atrial appendage closure after the introduction of the left atrial appendage closures in 2007. And these devices, such as, for example, the Watchman device here, there have been multiple multicenter randomized trials that show that this relatively new method is at least non-inferior to systemic anticoagulation.
Perfect, thank you.
So that was the missing part.
Yes, I think we have everything.
Thanks, Dr. Borek. That was really good. I had one question on how does it prognosticate in terms of the depth of the scar and whether to go through the endocardial or the epicardial approach, and how much does that impact the thickness of the scar, the transmurality? Does it really impact the decision making and the prognostication of these patients?
So we are talking about the VTs in a left ventricle right now, right? Yeah. Definitely, that's why we are looking at the layers. And I think with the new sequences where we have, I think we use the sequence with 1.4 millimeters. So you can have a 10 slices in a 10 millimeters, 12 millimeters myocardium. And the transmurality plays a role, of course. So if you have a transmural scar, it's usually not conducting any electrical impulses at all. So it's isolating, right? So the less transmural the scar is, the more border zone you have, and worse is the outcome of these patients. And I know that EP lab, I'm a radiologist, I don't do these procedures, but they, in these cases, they kind of use this lava procedure where they, when they ablate a large area of the myocardium. And if the scar is, or if the border zone is primarily epicardial, then sometimes they do even a epicardial ablation as well.
And are you also calculating the extent of scarring in the LA?
We usually don't. No. So for the PVIs, there is this DCAF study, but there was a lot of discussion whether it's real or not, and that's why everybody was so excited about the DCAF2 study, whether it has a prognostic value, and it didn't. So you could see that it actually doesn't matter. So we really just describe the anatomy and rule out the thrombus. Great. Do you measure the?
No, but it's a lot of times we get asked for scarring within the left atrium and atrial scarring. So because that is definitely going to have relevance in the future. But no, we haven't been quantifying it. But I think we're going to have to get there.
Yeah, I mean, procedural, yes, you can clearly see the scars after a PVI. But really in patients who are getting a PVI for the first time, we usually don't do it on a daily basis, no.
Great. Cool. Any questions? Right, it seems like everybody's really thrilled with your talk. And Cool, great. Thanks. Thank you so much. It's been a pleasure having you through this. And do you have anything to say about the? Did you listen into some of the TAVR and the other post-procedural complications? Do you have any comments on it?
Yeah, so I saw the other talks. That's great, and I think I'm going to be talking about one more talk about the ASDs, and I think I'm going to be mentioning a little bit, the measurements for unplugged cylindrical occluders, and I will not show a nice case of a migration, but I think it was something what Sandeep was showing, right?
Great. So Sandeep has.
Yeah, so Borek, we are taking just 10 minutes break and we have preponed your talk to the next talk so that you can have some more rest after that talk. So we will just, so we'll take your talk first and then we will continue with the rest of the program.
We won't let Sandeep steal your thunder.
So just a 10 minutes break, guys. We can break for tea, grab your tea, have some cookies and come back within 10 minutes. And we will start with the
Borek.
next talk.
Thank you. So we'll see you in 10 minutes.
Wonderful. Thank you so much.
Person C. Can we have the lecture?
Hello everyone, my name is Borek Foldyna. In the next 20 minutes, I'll be talking about how to assess device closure suitability on CT. These are my disclosures, none of which is related to today's talk. So before we talk about the imaging, it's important to understand what is ASD. ASD are abnormal connections between the right and left atria. These defects are common, accounting for approximately 10% of all congenital heart disease cases. Secundum type ASD is the most common one with 60 to 75% prevalence and twice as common in females compared to males. In general, ASD leads to a left to right shunting due to the higher pressure in the left atrium compared to the right atrium. And in a small portion of the ASD patient, it can lead to pulmonary hypertension and Eisenmenger syndrome and to shunt reversal. So we have done shunt from the right to the left. We know that only 50% of all patients with ASD develop symptoms, most common dyspnea, fatigue, atrial fibrillation or flutter, right heart failure, or pulmonary hypertension, and we know that these symptoms appear usually in their 30s or 40s. We also know that only large ASDs become symptomatic, while small ASDs, usually below 2 centimeters, are usually not causing any symptoms. Here you can see the other types on this image of the ASDs. So the secundum type, so ostium secundum type, is followed by ostium primum with 15 to 35% of prevalence, and superior sinus venosus 4 to 11% of the frequency among the congenital heart diseases or ASDs. For those who are interested in more detail, I can recommend a book chapter written by our colleagues Jenna, Sandeep, and Nina about congenital heart disease in this particular table, which is a screenshot from this chapter. You can read about the ASD types, their location, but also the embryology and also the association. Yes, the associations are important. If you are looking at the patients, for example, Holt-Orban syndrome, you can find that you should also be looking for secundum type ASD. as many ASDs come together with other congenital heart defects or other comorbidities. Regarding the images, let's look at the imaging features of ASD. The backbone of the imaging is echocardiography, and it always has been echocardiography, as you see on the left. Here is a representative example of a 4-chamber view with a large connection between the right and left atria and corresponding flow signal on the Doppler imaging right here. Sometimes 2D imaging can be challenging, especially in cases with multiple ASDs. Here, 3D echocardiography can be a great help, as you can see in a lower image with 2 large septum defects next to each other. These are not well seen on the 2D images, but you can really clearly see them here on the 3D image. Cardiac MRI is an increasingly popular method as it allows precise anatomical visualization of the ASD, and moreover, it allows for flow measurements, so using a phase contrast imaging to quantify potential shunting. CT, on the other hand, has a very high spatial resolution and is usually used for pre-procedural planning, so for the anatomical assessment. Here you can see 2 examples of atrial septum defects with contrast flowing from the left atrium into the right atrium. Here, large defect on a cine image, and we see how the contrast is blushing into the right atrium. Here, a small defect, this is a type 2 defect, with a little kind of a tunnel or connection between the left atrium and the right atrium. These are real ASDs if somebody's talking about a PFO. So these persistent foramen valleys, these look a little bit more like a channel. So we see actually the membrane over the ASD or over the connection, and these are not considered real ASDs. So this is a screenshot from a study that investigated the agreement between different modalities. And as you can see, there is a good agreement between, for example, the 3D echocardiography on the left and the CT images on the right. I think everybody can see these 2 large defects in the atrial septum on an echo and also on the CT here. So if we have such a good agreement between the modalities, what are the recommendations? So the relatively recent ACC guidelines for 2019 show us the current recommendations. In general, if you are looking for relatively large structures like atrial appendage thrombus, spontaneous echo contrast, or aortic atheroma, cardiac masses, or vegetations, the guidelines recommend a TTE or 2D TEE. If you go into a little bit more into the nitty-gritty and look for details, for example, anatomy assessment for planning for percutaneous device closure, the guidelines recommend 3D imaging, in particular, including echocardiography, so 3D echocardiography, but also MRI and CT. So especially CT-based ASD assessment is increasingly popular as it provides high-resolution images with wide field of view, allowing for multiplanar reconstructions. These advantages, for example, compared to echocardiography, allow for detection of concomitant defects and comorbidities. CT is reliable for ASD detection, shunt quantification, and also help us to select candidates for percutaneous interventions. Compared to open heart surgery, where the atrial septum can be inspected directly, the success of the interventional procedure depends on accurate pre-procedural planning, just like, for example, TAVR, the same thing. However, atrial septum morphology can be very challenging, and variables like size of the ASD, its location, or the appearance of the boundaries and margins are important. So let's look at how different ASDs look on cardiac CT. On the left, you can see the superior sinus venous type with a large defect. In the posterior superior portion of the atrial septum, the ASD are often associated to partial anomalous pulmonary vein returns, as you can see on the next image right here. Here, you can also see the very large pulmonary arteries. So as I mentioned at the beginning, an ASD can lead to a pulmonary hypertension, and here this could be a sequela or a sign of a pulmonary hypertension in this particular patient. The next 4-chamber view visualizes a shunt almost at the level of the inferior vena cava, corresponding to an inferior sinus venosus type ASD The last image shows an unroofed coronary sinus right here on the right side, which represents a relatively rare ASD type, which is often associated with persistent left superior vena cava. So if you see unroofed coronary sinus, or vice versa, if you see a persistent left superior vena cava, always look for the contrapart. So let's say you have a symptomatic patient with a newly detected ASD. What are the treatment options? We know that the closure in adults is associated with higher survival, less symptoms, and less cardiac remodeling. So it has a good effects on the outcomes. However, there are several studies showing that the benefit for elderly patients, usually over 65-year-old, is unclear. At the moment, ASD closure is recommended in symptomatic individuals and those with right atrial and right ventricular dilation and relatively large shunt volumes with QPQS over 1.5. Let's talk a little bit about percutaneous ASD closure, which is becoming increasingly popular due to its minimally invasive nature. In the center of this procedure is the ASD occluder, this device. There is a variety of these devices. There are usually dual discs, so you can see this 2-disc pretty much in all of these types of devices. And they have all detachable cables, so kind of introducers and sheets, how you can get it into a place. And it can be used for ASDs that are usually smaller than 4 centimeters with rims larger than 5 millimeters. Below you can see the examples of these devices with Amplatzer here on the upper left corner. The most common one, most popular one is, at least in our clinic. On the right side, you can see a occluder on a CT image here connecting the right atrium and the left atrium, and with the one disc in the right atrium with the other disc in the left atrium. And you can also see that there is a certain oversizing of the discs relative to the size of the ASD, which is here in the middle. And these are the so-called rims here in the middle, and these are needed to anchor the device and to keep it in place. And here is a nice MIP image of the entire device, again with the 2 discs. So what are the measurements needed for the intervention? One important measure is the ASD size. We know that the larger is the ASD, the much more difficult is to treat the ASD. These ASDs have often small deficient margins and need larger devices. However, the majority of the type 2 ASDs are between 10 and 20 millimeters. So we see almost 2/3 or around 2/3 of the cases are in this range. 1/4 is between 20 and 30, and only very, very small amount of the ASDs is outside of this range. In the last 10 years, there has been a huge development of new occluders, and some companies even offer custom-made large devices for problematic cases. I saw companies that, for example, use CT images to print out a 3D model of the heart and then model a occluder, specially custom-made for the particular patient. And this is actually a recently published case report from a patient from India who received a very large 48 millimeter occluder to treat his large 44 millimeter type 2 or secondum type ASD. And as you can see in the 4-year follow-up on this CT image, the large device sits well without any evidence of migration, leakage, or fracture. So this was a full success. And this little, this particular device also has a little fenestration in the middle to allow a little bit of a shunting. Okay, talking about the size of the ASD, it is important to mention that we should always measure the ASD in the systolic phase, as the ASDs appear larger in the systole compared to diastole. You can see it here on the images. On the left, we have the diastole. On the right, we have a systole, and the ASD is larger on the systolic phase, and here's the corresponding study showing the same results. And this is something that is comparable to other measurements, for example. That's why we measure our aortic annulus also in a systolic phase. The other measurements which are needed to do, which we need to do are the so-called margins or rims. In general, these margins should be larger than 5 millimeters to be able to hold the device sufficiently. The figure on the right displays the areas that needs to be measured. These areas are named after the neighboring structures. For example, the right upper pulmonary vein rim, the aortic rim, or the IVC rim. The size of these rims is closely related to the ASD size and location. So as you can imagine, the larger the ASD is, the smaller are going to be the rims. And if, for example, if you move the ASD towards the anterior portion of the atrium, towards the aortic valve, then the aortic rim is going to be smaller, while, for example, the posterior rim is going to get larger. So the size of the rims is important, and also the location. And we also look for if we have multiple rims, or multiple ASDs, sorry. This is an example of a study which is almost 20 years old. It is already shown that the size of the rim matters. Here, the group A with a successful transcatheter ASD closure had a significantly larger rims, for example. So this is a factor, this is a variable which is known for almost 20 years. So this is something what is very important for the measurement and also for the pre-procedural planning. So how do we measure these structures, these rims? So the first step would be the identification of the ASD, as you can see in the left upper image. And after we identified the ASD and place our crosshair in the center of the ASD, we rotate the ASD so it aligns with the interatrial septum in at least 2 planes. And then looking at the third plane, we have the ASD in front of us, so we can size it, we can describe the location of the ASD, for example, and determine its size, basically. Going back to the other planes, we can rotate the crosshair around the center right here and look at the other planes and measure the rims as needed. Here we can basically stop at every station, like clockwise, for example, and go from the aortic, for example, to mitral rim, then to CS rim, to the IVC rim, and so on, and provide all these measurements here. Or for examples, the mitral, the IVC, the posterior rim, and the aortic rim. So here are a few examples of a rim deficiency. We talked about it a little bit. So everything what's below 5 millimeters is deficient. The aortic rim deficiency is the most common one. So in this area right here, and it's often associated with left atrial disc prolapse and leakage, while the second most common is the IVC rim. So here in the lower part of the interatrial septum, and is often associated with device embolization. In general, you can see the deficient rim are small or entirely missing. So as you can see on these images right here, for example, the IVC rim is very small, but as a rim, and this particular patient is completely missing. Here is a list of morphological variations sorted by their frequency. Again, we see deficient rims, but also ASD location, perforated aneurysm, or multiple defects play a role. And multiple defects, as you can see here on the 3D TEE images, may need multiple occluders. So the planning is slightly a little bit different. And here we need to improvise based on the anatomy, how we describe the rims and the connection between the ASDs. To sum up, ASD is the most common congenital heart defect and often asymptomatic incidental finding. We learned that ASD usually leads to a mild disease spectrum and becomes symptomatic only in a large ASDs. Echocardiography, MRI, and CT provide us excellent images for ASD detection and anatomy assessment, while 3D imaging such as MRI and CT allow for precise measurement of atrial anatomy, which is crucial for the successful ASD closure. Therefore, CT can guide the clinical management of patients with ASD. Thank you very much.
Thank you, Dr. Borek. That was wonderful. Any questions from the audience? Okay, I have one. Regarding the ribs, you mentioned, aortic side,
Hello everyone, my
side.
name is
So are there
Borek
different
Foldyna. In the
cutoffs?
next 20
or
minutes, I'll
for
be
the-
talking about how to assess device
Sorry.
closure suitability on.
Can you, yeah. So the rims, are they different at different levels, or it's a fixed rim size which you want on all sides?
Well, the deficiency is usually 5 millimeters, but as mentioned, there are few vendors that are actually making custom-made occluders, so they can kind of compensate for it. But we usually look for everything was less than 5 millimeters. Okay. And there are a few studies actually showing that not only the one size, so kind of the the length of the rim is important, but also the thickness, right? So it's not the length only. So even if you have a long rim, which is very thin, it doesn't warrant that your device is going to be stable and anchored.
Okay.
Actually, in my experience, my cardiologists normally request for an MR. So we normally do this on the MR, the rims. And how do you feel about it?
Sure, if you have a good sequence, maybe a good 3D sequence, and maybe good SSFP images where you can see it nicely, then it's fine.
Because we really need to then, we definitely need to, pre-decide how we're going to get it. So definitely it's a lot more effort. But the fact that we get it in the systole, diastole, and we get a moving image of the ASD just makes it more accurate.
Yeah.
To be very frank, actually, if we talk about ASDs less than 15 mm, sometimes we are not sure, less than 10 mm, we are not sure whether there is a ASD or not, because, we think there is a defect, there's a contrast on both sides in your both atria. So a thin membrane septum may be misinterpreted as an ASD on the CT or vice versa. So I mean, as a rule, I tell my residents, if you don't see a large ASD, clear-cut ASD, or you should see some flow differentiation, some flow going, contrast going from one atrium to another before you say ASD. So we mentioned no large ASD seen. Small ASD, we are reluctant to report unless we, have the same thing written on echo also.
No, that's true. And, if the cardiologist really wants to know whether there is an ASD that is relevant, then they usually do a bubble study, right? So it's not really a CT or MR decision usually. So when the patients come to us, the ASD is usually known and they just want to know the measurements.
Yeah, because you sometimes have these aneurysmal septums. And the other problem is that, so that's why I prefer the MR, because at least you can see the flow and you can, quantitate it as well as look at the rims. But thank you. Great talk. And
one last question. So you as a follow-up, do you do CTs in all the patient as a routine? Like we do in stent grafts, for example, aortic stent grafts, we do CTs irrespective of whether they are symptomatic or not. So is it the same way, or you do it only when the patient is symptomatic? Or on echo if you see something,
So honestly, we don't do it very often on a CT. So usually I see unplugged patients done even without a CT, right? So without our imaging, our 3D lab is, 3D echo lab is pretty good. So I think if they say you saw the distribution, right? The most of the ASDs are relatively small. And if you have a very small ASD,
is there a role of CT? I mean, echo would be good, but if, there is a doubt, suppose MR, would be a better investigation. Personally, I think. But is there a role of CT also for post-op after the device closure?
You mean for the leakage? For the RR device leakages?
Yeah, or probably some complications following,
so we could do a CT definitely, but it's not done in every patient.
Okay. Thank you very much, Dr. Ravi.
So thank you very much, Dr. Borek Foldyna. And guys, we should have a great round of applause for Borek. He's still there, staying awake for us. And we must say good night to you now, Borek, and you can have your sleep, nice, sweet sleep.
Thank you.
Wonderful. Thank you so much for having me.
Thank you so much.
And have a nice rest of the conference. Thank you. Bye.
So
Who's our
moving
next
forward,
speaker?
yeah. So I again request Dr. Sandeep Hedgire to come on dais to deliver his talk about post-procedure imaging, including complications.
So Electrophysiology So